what we've done at Lakes, as you guys probably already know anyway, is we've worked on constipation, as have many of you. So our primary aim was to reduce the incidence of constipation related to opioid use in orthopaedic inpatients by 50%, from 57.4 to 28.7, so that's off our baseline data, by March. And we also had a secondary aim, which was to reduce the overall harm relating to opioid use by 25%. And that was on the basis that if we drop the constipation rate, then that must reduce our overall harm as well. And just to see how much extra we gained in terms of awareness, even though we weren't actually aiming at other harms. So our scope was around orthopaedic inpatients. So that's orthopaedic inpatients on the orthopaedic ward. So people who've been outlined to other wards, we haven't actually included because of the fact that we wanted to be, our interventions are particularly directed in that location. So our list of interventions that we've tested, these are all actually the change annotations that are on all our control charts and run charts. The newsletter and education has been quite useful. So everything that we've done, everything that gets discussed in a nursing staff meeting on the orthopaedic unit then goes into their newsletter that the CNM writes. And she's been quite supportive about getting messaging out every time we've been trying something new. The stickers that we're talking about there are actually around the antiemetic testing. So we're trying to reduce the use of ondansetron because it's known to be constipating as well, and we often co-prescribe it with opioids. The house officer rotation we had to chart because we showed how sustainability cannot be achieved occasionally, because you'll see that on the data. And then the prunes and kiwi crush, we got funding to do a 3-month trial for having prunes and kiwi crush on the breakfast trays. And, when we said, well, we want to do small tests and things, you can't say that when somebody gives you the money for 3 months. You don't say no when somebody gives you money for 3 months. You just do it. And it was low risk as well. So what we did do within that is run PDSAs within that larger test around what type of information was most effective to actually increase the uptake of the prunes and kiwi crush. So we ran what's called a planned experiment. The results that aren't validated yet, they're out for expert opinion that is still pending. But it looks like written information was most effective. We went to Grand Round. We talked to the anaesthetists. The anaesthetists have actually been brilliant in supporting us in what we've been doing once they had data. And then the second house officer rotation, we actually, Claire over here, who's one of our house officers, went to a lot of effort of making sure that the incoming house officers knew what was expected of them, and we didn't actually lose the sustainability part of that, and we've got plans in place to make that permanent. And then the 1st of October, we actually continued with the prunes and kiwi crush because it was giving us good results. So very quickly up there, the top 2 charts are very similar. The one on the left is from audit, from the patient's file and observation sheet as to who became constipated according to the national definition. And on the right is a summary of a huge amount of work in interviewing patients. So we've actually interviewed over 200 patients, doing sort of the 5 to 6 a week, and then in addition to that we interviewed over another 200 as part of the planned experiment for prunes and kiwi crush, which was a much simpler, quicker questionnaire. So even though the actual percentages on both of those charts are slightly different, you can see the improvement in both of them. So the bottom left is patients receiving prophylactic laxatives. So we did collect prescribing rates, but actually the prescribing's no good if the nurses don't administer. So we figured if they're being administered, then somebody's clearly prescribing it. So that's the process measure we've chosen, and patients receiving kiwi crush is fairly self-explanatory. Then the top left is just the outcome measure relating to our second aim. Nausea and vomiting, we were documenting it anyway, but then we wanted to use it as a balance measure for reducing the use of ondansetron, because a lot of the clinicians were concerned that if we took ondansetron away, we might have an increase in nausea and vomiting, but actually we haven't, and they're actually quite enthusiastic now that they've got that data, and they feel safe to actually change their prescribing practice because somebody's got their back. We're watching what we're doing. The number of patients who are given ondansetron, it looks like it's decreasing. I wouldn't say it was definitely sustainable or anything there, and that red special cause where it went up, we ran out of stickers. We had a supply issue, logistics. So we did want to know a lot more information, so this looks like planned experimentation for those people who are improvement advisors, but it's not. It was just a way of organising the information. But what we could see is that the prones and the laxatives seem to have the lowest rate at a very, very crude glance. It's not, it's just an indication. Pres Kiwi Crush and laxatives together was the next most effective, and then Pres Kiwi Crush. And out of interest, our cost of laxatives supplied to the orthopaedic unit has actually gone down. We've only got access to information from ePharmacy, unfortunately, which was in April, so we haven't got anything before that. And we think that's because when people do become constipated, you actually end up throwing a whole barrage of things at them. And it's not a lot of cost, but it's actually saving nursing time, doctor time, all that. So we've pretty much covered all of that. The teamwork has been quite good. We've worked really well with the kitchen, which has been really exciting for us, and they've been really excited to work with us. Data collection, I'm not going to repeat what everybody else has already said, except to say we agree. And our pharmacy staff is in a bit of a state of flux at the moment, to say the least, but it's going to get better. And changing nursing practice has actually been the hardest. Changing doctor practice, which we thought might be the hardest, wasn't. It turns out they like data. And I think, we're proud of achieving the aim. We just need to make sure we keep on with it, and there's always room for improvement. We still do have a sort of 27% problem, so we've still got plenty of room for improvement. Never ends. Cool. Thank you.